So wonderful. Today I'll be discussing endoscopic suturing for weight regain after bariatric surgery. I have no disclosures, and this is the full 7 seconds that they required. We did it. So objectives of the talk today, we'll be discussing the frequency of weight regain after bariatric surgery, therapeutic options, expected outcomes, technical considerations and approaches, post-procedure protocols, as well as future directions. So why does this matter? Surgical failure, quote unquote, is common. Many patients experience weight regain or inadequate weight loss, though there's no consensus on really defining surgical failure. Some define as an increase more than 10 kilograms from the nadir weight, an increase of a BMI of over 5 from the nadir BMI, weight gain to a BMI over 35, excess body weight of over 50%, or even any weight gain. But the numbers are there. So in this study, they defined failure as a BMI over 35 and an excess body weight of over 50. And this is a long-term study of over 10 years. And importantly, patients with a starting body mass index of less than 50, they found that over 20% long-term maintained a BMI of over 35. And those with a starting BMI over 50 maintained a body mass index over 40 in 35% of patients. So the numbers are there. And there's multiple studies. This is another one, 15-year study. We see this graph in additional studies that show the longer-term data, but really we often see the nadir weight at 1 year, a plateau around 8 to 10 years. As you can even see from the graph here, most regain at least 30% of the lost weight. And in this study, about 20% regain all of their lost weight. Another study from 2021 showed 1 in 6 patients after bariatric surgery had over 10% weight regain. So we can expect as bariatric surgeons, as providers who take care of these patients, that a large portion of our patients will fit into this patient population. So there are many causes of weight regain, and those separate into categories here, they're often multifactorial, from anatomic to dietary, psychiatric, behavioral. Focusing on the anatomic, is it the GJ anastomotic diameter, the pouch size, the sleeve size? Is there a gastro-gastrofistula? And of course, for the focus of today's talk, we'll be focusing on the anatomical considerations. So here you see a dilated GJ anastomosis. And here in this study, we see that relationship with the size of the stoma basically linearly correlates with both uncontrolled eating, and here on the graph on the right, with increased weight regain, and this is after a 5-year study. It's almost a stepwise progression as you increase stoma size. So what options do we have? We know about the surgical options, more invasive, even some studies showing 14% of serious complications, so we'll focus on endoscopic. And though I won't be going into most of these, important to note that there are many modalities endoscopically that we can help these patients post-surgery, including an over-the-scope clip, various ablation techniques that are often protocolized with multiple treatments over 8 to 12-week period, plication use and devices, but we'll focus on suturing, post-bypass, a transoral outlet reduction or TOR, and post-sleeve, an additional, we do ESG. So in terms of just looking at big picture for a TOR procedure, we see a dilation of the gastrojejunal anastomosis, and after the procedure, we would expect a decreased size of the anastomosis. Before we go into more details of that, we'll kind of first discuss patient assessment and patient preparation. Really, really important that before considering treatment of these patients that we redo a complete medical assessment, that we're not missing anything. We're treating them from head to toe, and that we've reassessed all of their medical comorbidities and ensure that they're optimized for the procedure. In addition, they need to see a registered dietitian and have a formal consultation as well with our psychiatric providers. A lot of patients will feel like this is similar to their bariatric pre-surgery protocol, and in a lot of ways it is, because this is, again, another intervention that requires those consultations for improved outcomes. And in terms of anatomic evaluation, there are some institutions that absolutely require an upper GI or an EGD even prior to those other consultations. I found that our patients tend to benefit from those consultations. They enjoyed that process. They benefit from it broadly. And so I advise the patients that I will be doing a diagnostic EGD at the time of the TOR, and there's a potential that we do not move forward if there's not any sort of anatomic benefit that we can give them, and most are very agreeable. In addition, there are some institutions who require medical weight loss programs for 3, even 6 months. We do this routinely for a lot of our patients, and they've found benefit both pre as well as post-procedure. And always reminded of exclusion criteria from patients who have abandoned Roux-en-Y gastric bypass, patients who have active eating disorders, substance abuse, coagulation concerns, and the like, to just give yourself pause if you see these in your patient base. So when discussing revisional procedures for bariatric patients from surgical to endoscopic, important to discuss the expected outcomes. This study, published in 2020, shows 5-year outcomes after TOR for patients who regained weight after root-and-wide gastric bypass. It was a retrospective review. Over 340 patients were included. There were no serious adverse events. And importantly here that you can see from these two graphs is really the durability of these procedures. So the one on the left shows that on average, patients lost over 10 kilograms that sustained itself. You see the 1-year mark and then the 5-year mark. And then on the graph on the right, percent total weight loss, nearing about 9% for the vast majority of these patients. And again, from the 1-year mark, 3, and then even to the 5-year mark, it's sustained. So we would expect some positive outcomes with overall low risk for these patients. So just to kind of give a sense of procedure setup, I do use general anesthesia. There are some providers who use MAC. I like protecting the airway. And I do talk with anesthesia about antiemetics early and often during the course of the procedure. I position my patients in the left lateral decubitus position. I do currently use an overtube. I do place that with the first initial diagnostic scope. Initial evaluation of the outlet, the pouch size, the jejunum, ensure that there's no contraindications and that we're all here for the right reasons, that we can actually help the patient. And of course, use CO2 for insufflation. The next step is tissue preparation. So ablating the mucosa around the circumference of the outlet, ideally 360 degrees and ideally about 1 centimeter in width. Argon plasma coagulation is recommended, but absolutely can use cautery if you don't have access to that. Below you see an APC setting, but depending on what your use is, some providers use higher watts or variance in flow, but again, you just want to ensure you're on the gastric mucosa, not the small bowel mucosa. A recommendation from Chris Thompson is that he does use simethicone. He injects a large amount down the jejunum after APC, as it helps with gas bloat as well as abdominal pain, and helps, essentially, he's seen in his larger number of patients that it helps his patients get home sooner from the recovery unit. So now to suturing patterns of the outlet. So the objective is to reduce the outlet size. That says pouch size, so that's a correction there. The outlet size to 5 to 8 millimeters, but absolutely the goal being below 10 millimeters. And there are a variety of suture patterns that you can achieve, or that you can use to achieve this objective. And sometimes you have to tailor your approach based off of patient anatomy or GGA size. A diagnostic scope, I always scope after the procedure, should absolutely not be able to fit through. I use a purse string, so B there in the image. It says 12 bites. I frequently 6 to 8, sometimes more depending on size. You do want a crossover of your first and your last bite. You want to make sure that your lead suture doesn't lock, because you want it to really pull through. And I also do use a pneumatic balloon. I use a CRE balloon to 6 millimeters to calibrate the final diameter. When you get, and I'll show an image later, but when you get edema from the APC, when you have a purse string suture, I like to know that I am not too tight, not too loose. As you can see in figure A, there's approaches that are interrupted sutures, starting from one side, moving to the other. Some people do a fish mouth kind of approach, where you have interrupted sutures from each side, moving towards the center, versus other various kind of running approaches. And again, you may need to adjust based off of patient anatomy or technical ability as you advance your practice. So again, the steps to really evaluate, prepare the tissue, suture the tissue, and your final result, you see in that upper right, a very small outlet compared to what was present pre-procedure. In that bottom central picture, that's actually a TOR that I did yesterday, and you can't really see the outlet. And again, because there's edema from the APC, that's a purse string suture. Another reason why I know with confidence that I did it over a balloon, and so I know that there should be some outflow, even though there will be edema in the first 1 to 3 days. So that, for me, in my practice, is something that I find very valuable. So then suturing patterns of the pouch. So again, the objective, if required, is to reduce both pouch volume with 1 to 3 sutures. Often you don't have, by any means, any room for more. And you definitely want to consider this for patients who might have a wide pouch. If you're able to maneuver your device to look full lateral, you likely have a wide enough pouch. If you can retroflex, absolutely your pouch is likely too large. If it's longer than 5 centimeters, you also want to consider reduction. I didn't mention this previously, but with the stoma reduction, frequently I'll try to put 1 or 2 additional sutures lateral to them to take off tension. A lot of this is tension related, and so you want to take off tension, but then in addition to this, you'd want to additionally consider some sutures to the pouch to decrease the size. And this can be linear, often anterior to posterior, a V pattern to meet back up anteriorly, or a very small modified U pattern. So in terms of post-procedure protocols, currently we discharge our patients home from the endoscopy suite or from the recovery unit. There are some institutions that admit for observation. It just depends on how your patients are doing. We are very aggressive with our antiemetics. Vomiting can lead to torn sutures, can lead to essentially negation of your entire procedure. And so We do give Zofran, scopolamine, and Decadron pretty much routinely to all our patients prior to induction or during the procedure, and additional antiemetics is needed, or whatever you use frequently in your practice. Just be aggressive. We also hydrate our patients. Ideally, they get at least 2 liters while they're with us, starting through the procedure and into the recovery unit. We expect that they're not going to be taking in much PO on that first day after the procedure, so it's important to give them that buffer. We prescribe our patients PPI, Carafate, ensure that all of their home medications are liquid or crushed. Additionally, Tylenol is often sufficient for pain management. Sometimes tramadol, sometimes narcotic, but really infrequent. But it is important to educate your patients that, yeah, in the first 1 to 2 days, you might have some gas bloat and some distension. In addition, they might have some mid-gastric pain and even some lower chest pain. But it's important to discuss expectations. It shouldn't be severe. And then in terms of diet, our current protocol is that our patients essentially just take water and ice chips the day of the procedure, just for comfort for the most part. They've already been buffered with the fluid that they've received in the procedure room. Then they're on a clear liquid diet for the following 3 days, then 2 weeks of full, 2 weeks of pureed, 2 weeks of soft, looking very similar to their post-bariatric surgery diet. In the study previously, in terms of outcomes, for TOR, that 5-year data, their protocol was a liquid diet for 45 days, and that's one of the longer that I've seen. Some institutions, it's 1 week of a full liquid diet, but the big picture is that you're not stressing your outlet, you're not stressing your pouch. You want this to scar in, you want this to heal. And so you might have certain patients that you say, adherence might be a problem. We're gonna really try to get you on a full liquid diet or a liquid diet longer. So you might have to modify, but in general, you want them on liquids or at least pureed as long as you can and as long as they'll tolerate. And then again, as mentioned previously, it's super important to ensure that this is a comprehensive approach. And so patients should have regular and scheduled visits with registered dietitians. We have APPs in our medical weight loss practice who are pivotal for our success of our patients, as well as see us and our MDs in our clinic to make sure that they're reaching their goals. And in terms of adjuvant therapy, it should be considered in patients who lose less than 3% of their total body weight at the first 3 months, or they have diminished satiety. That was an approach used in that TOR study, that 5-year data. And they found that 29% of patients actually did need some sort of adjuvant therapy. The majority of them, 39%, 29 of them had repeat endoscopy. Most of that was really just additional APC for scarring down, while 19% of them did start medications, and it really helped a lot of these patients. So important to kind of keep that in the back of your mind and let patients know that up front, that a good percentage of them will need additional therapies. This is also a super valuable tool for sleeve gastrectomy patients. So we can also apply this pretty much exact same approach. Dr. Venner will discuss the ESG, but essentially from distal to proximal, often a big U-stitch, small spaces between your bites. It's all about tension. But you see the big difference here from a laparoscopic sleeve gastrectomy patient to then an ESG after that, much more narrow and restrictive. Prior to this study, there was a key series of 5 patients that had actually similar results, but this is more recent and a larger patient base, but published in 2020, looking at patients who had ESG after laparoscopic sleeve gastrectomy for weight regain. It was a retrospective review. 12 international bariatric centers were involved. Weight regain was defined as a gain of 10 kilograms or more. 34 patients were included, and there were no serious complications, but really compelling results. So at 6 months, the average total body weight loss was 13%, at 12 months, 18%. At 6 months, the percent of excess weight loss was 51%, and at 12 months, 69%. So really compelling results, and something that we should also be really strongly considering for our sleeve gastrectomy patients, for which we see weight regain even more commonly. So in conclusion, endoscopic suturing after bariatric surgery is absolutely an acceptable option for patients with weight regain or inadequate weight loss. These suturing techniques appear to be safe, effective, and durable. They last the test of time. Even weight stabilization alone in this patient population is valuable. A lot of these studies show that over 80% of these patients at least stabilize their weight. And endoscopic suturing, important to note, is just one component of a comprehensive management strategy as discussed. But definite future directions and additional research is needed. We did develop a consensus on accepted indications, so we can develop screening protocols to really capture those patients who would benefit. If we have these protocols, we can share them with our PCPs, our dietitians, our APPs, and we can get the patients the care that they need that can give them that long-term benefit to better health. As well, develop standardized technical approaches. In that 5-year TOR study, the most commonly used modality was the purse string, and it showed really good outcomes. There have been additional studies that showed double purse string, has less dilation, but it also then comes with more stenosis and need for balloon dilation. So developing that standardized approach is also very worthwhile. And then lastly, developing standardized pre, intra, and post-procedure protocols. How much are these driving the positive or negative impacts? You have 10 institutions that are doing TORs and ESGs for weight regain. You probably have 10 different protocols. Super important to see and get a little bit more granular in terms of what's driving some of this. And then lastly, further research regarding these endoscopic techniques plus medications or other adjuvant therapies. As we saw in that other study, 30 to 40% of patients might need these therapies, so important to consider that early. Thank you all so much.